ora, koutou, and welcome to tonight's webinar. My name is Kate Barbie. I work for Fertility New Zealand, and it's my pleasure to welcome you to tonight's webinar, Fertility 101 with Dr. Michelle Bailey. For those of you not familiar with Fertility New Zealand, we are a registered charity. We work alongside all people facing fertility challenges. We have a dedicated helpline and we provide support, information and guidance to anyone at any stage of their journey. You can connect with us on Facebook, Instagram or LinkedIn. We encourage you to become a member. Membership is free. It gives you free access to our online forums. And by joining Fertility New Zealand, you support the valuable work we do for all New Zealanders facing fertility issues. Check out our website for more information. Just bring that over. Sorry about that. So check out our website for more information, download our free fertility fact sheets, or watch our recorded webinar series at your own leisure. I am delighted to introduce you tonight to Dr. Michelle Bailey. Michelle is a consultant at Fertility Associates Christchurch. And it's my pleasure to welcome you on tonight. If you have any questions or comments, please type them into the chat box and Michelle will respond to your questions at the end of the presentation, including any comments from Facebook Live. Thank you for joining us tonight and we hope you enjoy the webinar. Over to you, Michelle.
Thanks a lot, Kate. So welcome everyone. Thank you so much for giving up your valuable time on a Wednesday evening. I know there's a lot of other things you could be doing, so I'm very grateful that you've joined us. I'm grateful to Kate and Lydia for organising this and grateful that they put up a nice photo of me on the webinar. It's the most glamorous one ever taken, I think. So I've been asked to go through a topic called Fertility 101. So basically just a broad overview of some of the basic concepts about infertility and also fertility treatment. If everyone can hear me okay, that's great. If not, let Kate know. So some of the topics I'm going to go over tonight are looking at the definition and incidence of infertility, what some of the causes of infertility are, some of the ways that you can optimize your natural fertility, how the referral process works, so how you can get in to see a specialist. We're going to look at the CPAC scoring system, which is how you can access government-funded fertility treatment. Going to touch on what's involved with the initial consultation process and some of the testing that gets done at the time. We'll also talk a little bit about the basic treatment options that we offer. And then, as Kate mentioned, we'll take any questions at the end. Now, if anyone thinks of any questions later, they're also welcome to email them through to Kate and I can try and get back to you in the next few days to try and answer any questions that you've got. Also, just to mention, Fertility Associate is going to be running some webinars each month over the next year as well, which goes into a little bit more detail about some of these topics as well. So if you're faced with having infertility or fertility delay, one of the most important things to remember is that you are not alone, even though you feel like you might be. Fertility is extremely common in New Zealand, and we've shown in some research that by the age of 38, about a quarter of women will experience infertility and about 1 in 5 men. Now, how do you know you have fertility delay? How is it diagnosed? The way that we do this is in people that have been without contraception for 12 months, are designated as having fertility delay. So if you're having regular intercourse for a year without getting pregnant, and the reason that we chose this time frame is if you look at this graph, this is your chances of getting pregnant over time, and about 80 to 85% of all couples will be pregnant by 12 months of trying. Now, of the remaining 15 to 20% of couples at the end of 1 year, about half of those will go on to get pregnant between 1 and 2 years. So by the time you've been trying more than 2 years, there is a much lower chance of getting pregnant at that point. There is a bit of an impact of age, though, on your chances of getting pregnant. So this graph kind of goes through how that affects it. So this graph here again is the chance of getting pregnant over time. And in the light blue graph here, that's that similar to the graph on the other page, looking at your chance of getting pregnant over time. That's if you're 30 or younger. You can see with the dark blue line here, though, that if you are 37 years old, the chance of getting pregnant each month is a bit flatter and the peak is a little bit lower. And you can see for a 40-year-old, that effect is much more marked. So, although we might see 37-year-olds and 40-year-olds at 1 year, we might find that they're not getting pregnant just because of bad luck or a reduced chance per month of getting pregnant related to their age, and we may find there's not actually a problem with their fertility at that point. So, what are some of the causes of infertility? So, we group them into male factor and female factor, and they're roughly equally shared at about 40% of couples. Um, Also, around 20% of couples might have more than one factor, so a combination of male and female infertility. And that's why it's really important that even if we think we know why you're not getting pregnant, that we do investigate both of you because it's really common to find another unexpected factor to crop up. And sometimes a number of mild factors all accumulate to cause infertility. A number of couples also have what we call unexplained infertility, and that just means not that there's nothing wrong, but that all the basic tests have been normal. And sometimes, as we go through fertility treatment, we do start to see some reasons why you might not be getting pregnant. And the most important thing to mention with unexplained infertility is not to worry that we can't treat it. So just because we can't find the reason you're not getting pregnant, it doesn't mean that the treatments we can offer won't be successful for you. So, what are some of the causes of male infertility? So, there's quite a few different ones. We see men that have genetic causes for infertility, so conditions like cystic fibrosis or various chromosomal problems, which can mean that they don't produce as much sperm or any sperm, or sometimes that there's a blockage to sperm getting out of the testes. We also see men that have developmental problems with how their testes have developed, which means that they may not produce sperm in as great a numbers or as good a quality. So, risk factors for having a developmental problem are perhaps if you were born really premature, or if you had undescended testes when you were a little boy that required surgery to bring them down. And even if you have surgery, sometimes your testes don't always function that well, even later on. We also see men that have physical injuries as a cause for their infertility, and so that might be to the groin or testes directly. Or we do see a lot of men that have spinal injuries, which can affect their sexual function and ability to ejaculate. A number of men might have medical reasons why they have a low sperm count. So things like if you're very unwell with a cancer or you have chronic renal failure or poorly controlled diabetes, they can all affect your sperm count and sexual function potentially. Now, we do see some men where lifestyle factors can contribute to a poor sperm count. And these are things like if you drink a lot of alcohol, if you take a lot of recreational drugs, if you have a very poor diet. Now, um, sometimes if you change those factors, it can dramatically improve your sperm count. But a lot of the time, it doesn't it doesn't always cause a massive change in your sperm count, but I certainly have seen patients where it has made a difference. Now, some men, a high body temperature can affect their sperm count or the sperm quality. And usually that's men that might have a lot of spa baths or saunas a lot, or men that are professional chefs who spend a lot of time by very hot ovens. Or the other group that we see with this type of infertility are men that drive professionally. So they might sit, be truck drivers sit for about 10 or 12 hours a day potentially, and their testes get quite hot. So testes are developmentally designed to be outside the body because they function better at a slightly lower than normal body temperature. So if you're heating your testes up a lot, that can affect sperm production. We also see men that might be exposed to chemicals or hormones that can affect their fertility. And probably one of the more common hormones we see are when men take anabolic steroids to try and help with build muscle bulk. And you would think that taking testosterone would actually help your sperm count, but it in fact does the opposite, and it can drop it quite dramatically. And sometimes it doesn't recover if you take steroids for a long time. So this chart shows what happens to a man's sperm count um, over time, and this graph shows that one man who had normal fertility did a weekly sperm test um, for 2 years, and the rumor is that he was in prison, and that's why he had time to do this each week. Um, so you can see that the sperm count fluctuates quite a lot from week to week. And it's a little bit hard to see on this graph, but um, there's a wee line across here which shows the cutoff for what we consider to be a normal sperm count. And that's actually 15 million per mil on the sperm concentration. And you can see that even in a healthy, fertile man, that some of his sperm counts will be below that cutoff. So, although it's a pain to have to do more than one sperm sample, that's the reason we often ask you to do another sperm sample, is to see what your kind of average sperm count is and make sure that we're not seeing a really falsely spuriously low one or a falsely spurious high one. You also might be aware there's been talk in the media that men's sperm counts are dropping over time. And certainly, research has showed that in some countries, but not all countries, the sperm count in men has dropped quite a lot in the last 50 years. Um, so, this research showed it had dropped from 99 million per mil to 47 million per mil since the 1970s. But you can see even though that's a big drop, 47 million sperm per mil would still be considered in the normal range. And it's interesting because it hasn't occurred in all countries, and people are not completely sure why this is happening. It may be a number of factors, such as not trying to have a baby till you're later, possibly environmental pollutants or toxins. I put this slide in just so that the women that are watching know that when we talk about the effect of age on fertility, we're not just talking about the effect on women's fertility. So, this graph shows a reduction in all the different parameters we look at on a semen analysis. So, semen volume, concentration, total sperm count, total motile sperm, and what happens with that with age. Now, you do hear men that can father pregnancies in their 50s, 60s, and 70s, and like rock stars, and Charlie Chaplin famously had a baby when he was 73 with his partner. But you can see that all of the parameters we measure do drop dramatically over time. There's also a higher rate of um, having babies with chromosomal abnormalities if men are older, as well as things like autism and schizophrenia when you're an older dad as well. So, what about some of the causes of female infertility? So, the most common thing that we probably see in the clinic is women that don't ovulate regularly or don't ovulate at all. And the way that you would know you had this was if you had irregular menstrual cycles or possibly no periods at all. Some women that don't ovulate regularly also get really long periods. You might bleed for several weeks at a time. That's another way you can tell that. We also see women that have tubal damage or scarring, and the most common reason for that is if you've had an infection like chlamydia or gonorrhea. And the more episodes of that you have, or the more severe the episode is, say if you were in hospital with a severe fever and what we call pelvic inflammatory disease, that's more likely to cause tubal damage. We do also see tubal damage from other things, so people that have had surgery on their tummy or might have had something like tuberculosis affecting their tummy as well. Now, endometriosis is a condition where the tissue that's normally inside the lining of your womb and what you shed when you get a period can sometimes grow out in the pelvis. And when you get your period, that tissue also bleeds. And so that can cause quite a lot of pain in your tummy and inflammation and potentially scarring. Now, in the general population, about 10, maybe 15% of women will have endometriosis. But if we look at people in fertility clinics, particularly women with unexplained infertility, we think around about 50% of people will have some endometriosis. And if you looked at patients going to a gynae clinic for assessment of pelvic pain, probably between 70 and 90% of them will have endometriosis. So fibroids are benign growths of the muscle of the uterus, and they are super common. So around half of women with at childbearing age will have fibroids, and most of the time they don't cause any issues with your fertility. The ones we get concerned about are those that are very large or that's right inside the lining of your uterus and cause a foreign body effect to embryos implanting. The other issue is sometimes they can press on your fallopian tubes and cause a blockage of the tube. Now, we see quite a lot of women who have something called low ovarian reserve, meaning that the number of eggs that they have left in their ovaries is reduced compared to what would be expected for their age. So basically, their ovaries think they're older than what they are, and this can affect their ability to get pregnant. We also see a lot of women where age is probably the biggest contributing factor to their fertility delay. And certainly at Fertility Associates, about a quarter of our patients now are over the age of 40. So this graph here looks at the chances of conceiving related to your age. And what I want you to do is to look at the blue bars here, and that's the chances of conceiving naturally and how that relates to your age. So the chances per month here we're talking about. So you can see that a woman who's 31 or younger will have about a 20 to 25% chance per month of getting pregnant. And that comes as quite a surprise to a lot of women because we spend so much of our teens and early 20s trying to prevent getting pregnant and avoid being pregnant if we don't want to be. That when people hear that actually they only have about a 20% chance of getting pregnant, they're very shocked. And you can see that that chance stays relatively stable. And then once you hit your mid 30s, the rate of decline does start to increase. And you can see here, by the time you're 45, most women with normal ovarian reserve for their age would have a very, very low chance of getting pregnant naturally. The red bars here are the chances of pregnancy occurring with IVF treatment. And um, again, this follows a similar trend. So we have very high success rates in younger women. In fact, this is slightly old data. We're probably seeing a little bit higher than that now. And you can see that's relatively stable. And then that rate of decline really starts to increase in your late 30s. And again, by your mid 40s, even with a powerful treatment like IVF, we still have quite low success rates. And the reason for that is twofold. The first one is that women are born with all the eggs that they have. And even from the time you're an embryo in your mum's tummy to the time you're born, a lot of eggs have been lost, and every single month, a group of eggs starts the maturity process and then dies away if pregnancy doesn't occur. And by the time you are in your 30s, 40s, 50s, your number of eggs is quite depleted, and by the time you have menopause, there's very few eggs left. The other reason that older women find it harder to have a successful ongoing pregnancy is something called the embryo aneuploidy rate. And aneuploidy is the medical term for a chromosomal problem within an embryo. And most of those are caused by a chromosomal problem within the egg due to the egg being older. And this graph shows age and the chances of an aneuploid embryo. And you can see that women in their 20s and 30s have a rate of aneuploidy of about 30%, which again surprises a lot of people. So even a 30-year-old woman would have a 1 in 3 chance of having a chromosomally abnormal embryo. And that's part of the reason that humans generally only have one baby at a time compared to, say, bunny rabbits or mice who have big litters, because a lot of our embryos are not normal when they're created. You can see that graph is relatively flat again, and in your mid-30s, that becomes quite a sharp increase. And by the time you are 45, nearly all of the embryos that your eggs will go on to create will have a chromosomal abnormality. And what this means is that they are likely to not implant, so you don't get pregnant at all. They might cause an early pregnancy loss, or you could have a baby with a problem such as Down syndrome. So I put this graph in, well, it's a chart really, just to get people starting to actually think about planning their family, planning for the size of family that they want. So there's a lot of information on the slide, so I'll point you to the particular bits we're going to talk about. But this comes from a mathematical modelling study where they looked at what your chances were of achieving the family size that you wanted, whether you would or wouldn't consider doing IVF as part of that journey. So, if we look at the 90% chance of achieving the family size that you want, in the top section is in couples that wouldn't do IVF. If you actually want to have 3 children, this study showed that you should be starting to do that when you are in your early 20s. If you only want 2 children, got a little bit more time, you should be starting to try when you are 27. If you want 1 child, you should be starting to try by your early 30s. If, however, you would consider IVF treatment, you do have a little bit more time up your sleeve. So you should be starting to try if you want 3 children when you are 28 years old. If you want 2 children, 31. If you want 1 child, 35 years of age. The other sort of point to note on this graph is if you look at women here and here who don't start trying to have children till their late 30s or 40s, you can see they only have a 50% chance of having the number of babies that they want to have in an ideal world. Now, as fertility specialists, we don't generally get to have this conversation with people because we see people when they've already had problems getting pregnant. So, ideally, this is a conversation you should be having with your partner when you first get together, or with your GP in your 20s, starting to think about what size family you want, what that means for planning your life. We're going to talk about some lifestyle factors that are good to address when you're trying to get pregnant. And I apologise, there's quite a lot of information on this slide, so we'll just go through it sort of bit by bit. Um, so, one of the most important things when you're trying to get pregnant is to have a normal body mass index. So, body mass index or BMI is a marker of what your weight is for your height. And Normal is between 18.5 and 25. Now, women who are in the overweight category often don't have many problems with their fertility, so it would be ideal to be in one of these two groups here. Women who are obese do struggle to get pregnant more commonly than those with a normal BMI, and that's from a combination of factors. They often don't ovulate regularly or that well, and they may have higher pregnancy complication rates like gestational diabetes and high blood pressure, and much higher chance of having cesarean sections as well. Women that are underweight also sometimes can struggle to get pregnant. And you're probably aware that a lot of athletes, particularly ballet dancers and gymnasts, who are very underweight, often don't get periods because they don't ovulate regularly. And that's mainly to do with not eating enough energy to fuel the exercise that they're doing. So the ideal BMI is kind of in here to optimize your chance of getting pregnant. Stopping smoking is probably one of the most important things you can do to help with your fertility, and I would include vaping in that category as well. So we know that the chemicals from cigarette smoke get right into the fluid around the eggs inside the ovary. And we know that people that smoke actually go through menopause a couple of years earlier than they would have otherwise, just because those chemicals are so toxic to the eggs. So if you are looking for reasons to stop smoking, trying to get pregnant is a really good one. Now, I've just put a little section here on toxins. Some people do reduce their exposure to toxins when they're trying to get pregnant. So things like washing your fruit and veggies, not using too many chemicals on your body, and trying to avoid pollution. And, we certainly do think some of those can impact on your fertility, but it can be quite hard to avoid a lot of those toxins. They're very common in the environment, but some people do like to try that. Now, alcohol is teratogenic, which means it causes birth defects, and it can also cause a condition called fetal alcohol syndrome, which can cause developmental delay in children. So, for that reason, we recommend that when you are pregnant, you don't have any alcohol at all. Now, when you're doing fertility treatment, we also say that you shouldn't have alcohol after you've ovulated or when you've had a procedure done like an insemination or embryo transfer, because you won't know you're pregnant until a couple of weeks later. So we say don't drink in that time. A lot of people will still have the odd drink, mainly around the time their period comes, usually to commiserate because they're not pregnant and they feel a bit crap. And that is absolutely fine. You can certainly have, one or two drinks around the time that you know you're not pregnant. That's okay. Now, it's really important to try and have a healthy, balanced diet when you're trying to conceive. And I'm just going to mention folic acid, which we do recommend that you take a supplement for of at least 800 micrograms every day. And if your BMI is higher, you're at higher risk of neural tube defects, so things like spina bifida, which is what folic acid can help reduce. We recommend that you take a higher dose again, 5 milligrams. And just a note that if you get that from a health food shop or one of the Australian-based bargain chemists, they often are lower doses, so you need to make sure you're taking 800 micrograms a day. So if your tablets are not that high, you need to be taking a couple of tablets. Now, we also recommend that you follow a healthy diet. And we talk about a Mediterranean style diet or pro fertility diet, and that's reducing your processed carbohydrates and what carbohydrates you have, focusing on complex carbohydrates. We recommend that you have plenty of fruit and veggies and that you get your fat from healthy fats, so things like olive oil, avocado, um, nuts, and oily fish. There's also quite a lot of work being done on how your diet affects your microbiome, which is the sort of balance of good and bad bacteria in your body, particularly inside your gut, but also inside your uterus. And there is increasing evidence that a really good balanced diet with plenty of um, plant matter in the diet is best for your microbiome. Now, a lot of people will reduce their caffeine intake when they're trying to get pregnant, and certainly high caffeine intake is linked to stillbirth and miscarriage, but we're talking about probably about 5 cups of coffee per day. So we recommend that you maybe stick to a couple of cups of coffee per day when you're trying to get pregnant. And if you drink tea, you can have twice that because it's got half the caffeine of coffee. If you drink things like Coca-Cola or energy drinks, we would probably recommend that you stick to sugar-free versions and that you watch the portion size because some of those cans can be absolutely enormous and contain massive amounts of caffeine. It's not on the slide here, but I'm also just going to mention getting your vaccinations in order when you are trying to get pregnant. So we recommend you be vaccinated for rubella and chickenpox, that you have a flu jab if it's the flu season. And we do recommend that you get your COVID vaccine and boosters. There's currently no evidence that we have from mainstream data that the COVID vaccine affects your fertility or increases your risk of miscarriage. And we know that if you catch COVID when you're pregnant, you are much more likely to have severe disease. Another really important thing you can do to help optimize your natural fertility is to make sure that you get the timing of intercourse correct. Um, And there's lots of ways to monitor when the correct timing of intercourse is. And basically, there's 5 to 6 days leading up to ovulation when you can get pregnant. And for most people with a 28-day cycle here, they will probably ovulate between about day 13 and 16 of their cycle. So you should be trying to time intercourse in the lead up to when ovulation occurs. A lot of people get this a bit wrong. They think they need to wait for the egg to be released from the ovary before you can get pregnant. But actually, from the day after ovulation, you can't get pregnant in the cycle. So you want to be timing intercourse before ovulation. There's quite a lot of ways that people can now track when they're ovulating. So a lot of people use apps, and there's hundreds of different ones. Some are better than others. And just be aware that a lot of them do collect your personal data and may on sell it to third parties. So check the terms and conditions when you're signing up for those. There's also urine or saliva kits that can detect this hormone here called LH, which is the hormone that rises up really rapidly in the middle of your cycle to promote ovulation. So those kits pick the most fertile couple of days in that 5 to 6 day peak ovulation window. So they're really helpful for making sure that you're getting your timing of intercourse right, particularly if you are not able to have intercourse every 2 or 3 days, say if you've got roster clashes or you're really busy. Um, I'm just going to go through the referral process now. So that means the referral process to see a fertility specialist. And you can see from this wee picture I put in here, there's lots of different ways you can get to a fertility specialist, but don't worry too much. You usually end up in the same place at the end. So your GP can refer you for a publicly funded first consultation about your infertility, and usually you would be seen within around 4 months. Now, you have to meet some criteria to be eligible for a publicly funded first specialist consultation, and they are you need to be trying for a year or more to get pregnant, you need to not smoke or vape. For women, they need to be under 40, and there needs to be less than 2 children under 12 that live in the house with you. Your BMI also needs to be under 35. And if you think back to that graph on the other slide, that's actually in the obese category. Now, it's important to remember that you may not need to be seen at the public hospital to get this publicly funded consultation, depending on where you live. For example, here in Christchurch, we at Fertility Associates do see publicly funded consultation patients, even though there is also a public hospital clinic at Christchurch Women's. So you may end up being seen at a private clinic, even though it's a funded consultation. You can also have a private referral to the clinic, which means that you pay for that consultation. And at the moment at Fertility Associates, that's around $320 for a consultation. And you can get a GP referral for this. And a lot of people do this if they don't meet those eligibility criteria that were on the other slide. Some people also don't want to wait for the appointment that we can give them. So they want to be seen before that 4-month period. And again, you can pay for a consultation if you want to do that. We also take referrals from other specialists, and often that's other gynecologists. And sometimes the doctors at the public hospital will refer patients to us as well. Now, it's important to remember you can self-refer to the clinic. Now, not all specialists will take self-referrals, but we certainly do at Fertility Associates. Um, and it's important to remember, even if you're seen privately, you may then be eligible for government-funded fertility treatment after that. So if you can afford to pay for a private consultation and you think that you will be eligible for government-funded fertility treatment, it can sometimes save you a few months' delay if you do pay for a private referral in the first place. So when do we want to see you? So we recommend that if you're under 35 and otherwise fit and well, that you be trying for a year before we see you. Now, at Christchurch Hospital, their health pathway, which is the information for GPs, does suggest that if you have irregular periods, you need to be waiting 2 years before you're seen. But actually, at Fertility Associates in Christchurch, we're happy to see people at the 1 year mark, even if they've got irregular periods. For older women, so those over 35, we would often advise you be seen a wee bit earlier at maybe 6 or 9 months of trying, just because we want to make sure there's no problems and they get identified quickly. You would usually need a private referral in that situation because you haven't been trying a year, though. If you suspect or you know that you have a significant factor in your past medical history that might increase your risk of infertility, then I would recommend that you be seen earlier. So if you know your partner had chemotherapy when they were younger, they might have a low sperm count or no sperm. If you know that your mother had menopause when she was 30 years old, you can sometimes inherit that. So things like that, we would recommend that you be seen sooner than 1 year of trying. Now, as a patient, it's important to remember that some GPs know more about gynecology and women's health, and they're also more proactive about referring you to see a specialist. So, if you're talking to your doctor about your fertility delay and you feel they are not hearing you or not taking you seriously, then do be more proactive with asking for a referral or even seeing another GP. Or you could even refer yourself. I do hear a lot of people say, I was trying to tell my GP and they just kept saying, just keep trying, it's all right. So do be proactive if you're feeling like you're not being heard. Now, most of you are probably aware that the DHB system is getting abolished in New Zealand. It's going to be replaced by a national health service. And at this stage, we have no word how that's going to affect fertility referrals or funded fertility treatment. So I'll just talk a little bit about government or Ministry of Health funded fertility treatment. And the way that we see if you're eligible for this is to score you with a tool called the Clinical Priority Access Criteria, or CPAC scoring. This is a picture of the CPAC sheet here, and it's pretty hard to read, so don't worry, I'll summarise it on the next slide. But it takes into account a whole lot of factors, including medical issues, how long you've been trying, and social issues. So it takes into account the duration of time that you've been trying to get pregnant. It also looks at what causes for fertility delay you might have. And the things that actually get points are endometriosis, whether you ovulate regularly, do you have damage to your tubes, or do you have a poor sperm count or quality? And the more severe that problem is, the higher your medical score for the CPAC. If you have had a surgical sterilisation in the past, this decreases your score, but most people will eventually still be eligible for treatment. Um, for example, if a man's had a vasectomy, are eligible to be put on the publicly funded waiting list around 3 years after they first saw a specialist to talk about IVF or having their vasectomy reversed. Having one child in your relationship reduces your score. It doesn't eliminate the chances you can get scoring. But having two children in your relationship mean you won't be able to be scored. So, although this might seem a little bit unfair, it's basically a way that reflects the assessment of what the chances are of you conceiving spontaneously in time. So, you need a score of 65 points to get above the threshold to get on. And if you have more points than that, you don't get treated any faster. It's a threshold. Once you're put on the waiting list, you then usually need to wait about 12 to 18 months to get to the top of the list just because we have so many people waiting. However, at the moment, we are participating in a research study called the FIX study, which is looking at unexplained infertility and randomizing people to either artificial insemination or IVF to see which is more successful. And if you're eligible to go in that study, you may be able to access your treatment in around about 6 months. And that's probably going to continue recruitment till the end of this year. Now, we do understand that the system is not perfect, but New Zealand, compared to other countries, has a really small health budget. And so this tool has been developed over a number of years by my very eminent senior colleagues. And it was designed to try and assist those people who have a lower chance of conceiving spontaneously and don't already have children. There are a number of criteria that mean you will not be eligible for Ministry of Health funding for treatment. So if you are a woman and you smoke or vape, you can't get treatment. If you become smoke free for 3 months, we can then look at your scoring and we need a letter from your GP confirming that you have stopped smoking. If women are over the age of 40, we can't score them. You can be put on the list before you turn 40 and turn 40 while you're on the waiting list. That's okay. But if we see you after the age of 40, we can't put you on the waiting list. If you have two children in your current relationship or two children from a previous relationship that are under 12 who live with you more than 50% of the time, you will not be eligible. Those children under 12, if they then become over 12, we can then relook at your score though. You need to have a normal BMI and you need to have reasonably good ovarian function. So the cutoff for FSH hormone is 15, which is usually a sign of quite severely depleted ovarian function. Now, if you have poor ovarian function, you can still receive government funded treatment, but usually that would be egg donation treatment, not IVF using your own eggs. So, what does getting help with your fertility look like? So, when you book your initial consultation, which at the moment could be in person or it could be virtually via Zoom, we take a medical history from both of you, and that includes your past medical or surgical history, your family history, and we're trying to identify in your history whether there's any factors that cause us concern and make us think, hey, I think I know what's going on here. We also want you to have some blood tests, and we generally try and do those before the first visit so we actually have the results to discuss with you. So for men, we do an infection screen, and for women, we do an infection screen as well as something called a first antenatal test, which is doing all the tests to look for whether you're healthy enough to be pregnant. So we're making sure you don't have pre-existing diabetes, that you're not anemic, that you have good kidney function. Women also need an assessment of their ovarian function, and these are the tests we generally like to do in the first few days of your menstrual cycle. And we test two hormones, one called the FSH, which is a pituitary gland hormone that sends a signal to your ovary at the beginning of each month to ask it to grow an egg. And we also look at something called the AMH or anti-Mullerian hormone. And that's a different hormone. It's made in the ovary from the cells around each egg. Um, and when you have that consultation, we will look at your ovarian function and usually give you some indication of where you are in relation to the rest of the population. And it's pretty hard to see, but this is our graph of AMH here. And so this line here would be average ovarian function, this black line. But there's quite a range of variety in the population. So we will be able to tell you if you have high ovarian function or low ovarian function. Now, it's important to remember that ovarian function testing can't tell us definitely whether you can or can't get pregnant. So it does need to be discussed with a fertility specialist. Um, Now, we'll often also organise an ultrasound, which might be done at that first consultation or it could be arranged afterwards. Often we'll also want to do a special detailed ultrasound called a tubal patency test or saline infusion scan. And that's usually done at a radiology service and has to be done usually between day 5 and 9 of your cycle. Now, classically, this is described as the least nice test to have done when you're having your fertility assessed. So they put some salt water through a little catheter in your cervix, so it can cause sort of like bad period pain. So do make sure that you take a decent dose of pain relief about an hour before you have that test done. We also need to see a sperm test, and ideally, again, it's best to do that before the first visit. Can take about a week to get the results, so factor that in. That way, we actually have some information to talk to you about at the consultation instead of talking in theories. So once you've had your first consultation, we then set up investigations and then potentially treatment cycles will be organised from there. They are prescribed by your doctor and then managed by our team. Information following up on test results and things might be given in person. It could be via your clinic summary letter. It could be via text message, or at Fertility Associates, we have a new messaging app called SARV, or given to you over the phone. You may see both nurses and doctors during your treatment. And if you see a doctor, it may not always be the same doctor that you've seen for your first consultation because we do work as a team. Interval review appointments will be planned to discuss next steps of treatment if you're not having success, sort of as they're needed or if you want them. And again, a letter summarising the plan made at that consultation will then be sent out to you. At varying times, the CPAC scoring will be updated when new information comes to hand from any test results you've had or the more time passes. So there's four main core fertility treatments that we can offer. So I'm just going to touch on each of these now. The first one is ovulation induction, or sometimes called ovulation augmentation. Um, and the aim of this treatment is to get regular egg production happening if you don't regularly ovulate. If you do regularly ovulate, we sometimes we'll put the dose up a bit and we're trying to get maybe 2 or 3 eggs to grow in a cycle instead of one. Um, and we need to monitor you when you're doing this so that you can get your timing of intercourse right, and we make sure that you don't over respond and don't put yourself at risk of getting pregnant with 5 or 6 babies all at once, and that we make sure that you ovulate. We usually use tablets for this treatment, so clomiphene or letrozole, and you take those normally for 5 days at the start of the cycle. Sometimes we use injections of FSH hormone, so that pituitary gland hormone, um, but that's not used as commonly now because it's really expensive compared to clomiphene or letrozole, and it can take weeks for you to respond. And there's a much higher rate of overshooting and having to cancel the cycle because you're making too many eggs. So it isn't actually used as much as it used to be. So, as I said, we need to monitor you, and we do that through a combination of blood tests and ultrasounds during the cycle. Now, often if you go fine on the first cycle, you don't have to be monitored every single cycle, but some people there's issues and we need to tweak the dose or give you an injection to boost ovulation and things. So, in that situation, you might need to be monitored a little more closely. Intrauterine insemination is the kind of next step on from ovulation induction, and that's where we put prepared sperm into the womb at the fertile time of the month. And that process takes about 5 or 10 minutes to do, and it's a little bit like a smear test. We usually couple this treatment with clomiphene or letrozole tablets, or as mentioned, occasionally FSH injections if needed. The monitoring is very similar to ovulation induction, but a little bit more intensive because we actually need to see right at the point where you're going to ovulate so we can do the insemination before ovulation. So you might have more blood tests, sometimes more scans, but often still only one scan. And we often use urine LH testing kits to pick that most fertile time leading up to ovulation. So IVF treatment is our most powerful fertility treatment. And what happens with that is we use injections of FSH hormone to super stimulate your ovaries so we can get as many eggs to grow in that cycle as we can. Takes around about 2 weeks of injections to get to the point where we can collect the eggs. And for the second week of that 2 weeks, we also use an injection to block ovulation because we don't want you to release the eggs on an IVF cycle, whereas with the other treatments, we do want you to release the eggs. We then collect the eggs under ultrasound guidance just vaginally with a little day surgery procedure at the clinic. It takes about 15 or 20 minutes to do. Um, it's done under sedation, so usually IV sedation, very similar to if you had a colonoscopy or your wisdom teeth out. And actually, it's very well tolerated for most people. The most common thing I hear people say afterwards is, "Oh my God, that was so much better than I thought, and way better than a saline ultrasound." So, try not to worry too much about the egg collection procedure if you do need to undergo that. You can have a support person in the theatre with you to hold your hand as well, and they'll need to look after you that day. Do need a day off work that day and maybe a couple of days afterwards as well to recover. Once we get the eggs in the laboratory, our lab staff then fertilise the eggs and grow the embryos that result from that fertilised egg in the incubators. We'll then aim to do a transfer of an embryo 3 to 5 days later, and that procedure is very straightforward. It's quite similar to an artificial insemination, but instead of putting sperm in the womb with a little catheter, we put an embryo in. We'll also know at the day 5 to 6 mark whether you've got extra embryos to freeze. And what that means is you can then have further chances of getting pregnant just by doing a frozen embryo transfer cycle. You don't need to go through the full IVF stimulation and egg collection and all of that. And most people with good ovarian function will have some embryos to freeze. ICSI stands for intracytoplasmic sperm injection, and it was a technique developed in the early 90s to treat very severe male factor infertility. So prior to ICSI, men usually needed to use a sperm donor if they had a very low sperm count. And what we do with ICSI is once we've collected the eggs with the egg collection procedure, we then take the egg, which is sitting here, and we look at the sperm under the microscope and we find the healthiest sperm that we can find. Our scientists then give the sperm a little whack on the tail to stun it for a second, and they suck it up into this little catheter here. And this is the sperm sitting in a needle here. And then what the scientists do is they put the needle directly into the egg and then they push the sperm out so it's left sitting in the egg at the end and then they take the needle out. So it bypasses the sperm's ability to attach to the egg here and to burrow through this shell called the zona pellucida and to get in the egg and to activate the egg. So it bypasses all of those things. So it's revolutionised the treatment for severe male factor infertility. We also offer quite a number of other treatments that are not our core treatments. So we can offer donor egg treatment, donor sperm treatment, or donated embryo treatment. So that when another couple has undergone IVF and they have extra embryos frozen, they can then donate to another couple. We also undertake surrogacy, and that's become increasingly common. So um, gay male couples may use a surrogate, also women that have had hysterectomies for a medical reason, or women that have a medical condition that mean it's not safe for them to be pregnant can use a surrogate. We also can offer pre-implantation genetic testing, and this slide here shows that being done. So this is a day 5 embryo here called a blastocyst, and this is the bit called the inner cell mass what actually makes the baby itself. The rest of this tissue is called the trophectoderm, which makes the placenta and membranes. And so what our scientists do is they take some of the cells from the trophectoderm and they test them for genetic conditions. And that can be done for chromosomal abnormalities or it can be done for a particular genetic condition like cystic fibrosis or Huntington's disease. And if it's done for a genetic condition like cystic fibrosis, you may be eligible for some government funding to pay for that. We also treat same-sex couples and single people, and we also treat transgender patients. We also offer fertility preservation treatment, and that can include women having elective egg freezing if they want to preserve their fertility. We also see patients that have cancer that are going to be undergoing chemotherapy that might damage their ovarian function or sperm. Or sometimes people have fertility preservation before pelvic surgery. We also see a lot of men that now look at freezing sperm before they have a vasectomy. And the reason for that is a lot of men have second relationships once they've had their vasectomy, and it does make life a lot easier if you've got sperm frozen that you can use. All of our clinics in New Zealand have counsellors associated with them as well, and you can see the counsellor as part of your fertility treatment or even before. And that's because we know that it's a really difficult journey, and particularly when you're not having success, it can be really hard to keep going. So we all have counsellors that you can talk to help support you as you're going through treatment. Okay, well, hopefully you guys are more awake than this little sperm here, and we'll go through any questions that people have got, if people want to send them through. I can see a couple here already. Oh, it's just gone, Kate. What's going on there?
Hi, Michelle. So the first question is, what about stepchildren? So if one person already has a child, but the other person doesn't.
Okay. Yeah, so they are factored in. If you have children from a previous relationship, um, if you have custody more than 50% of the time, those children are under the age of 12, they are factored in. If they're older than 12 or the custody is lower, then we sort of look at that. But yes, stepchildren do get factored into the scoring.
Okay. And what are your thoughts on fertility acupuncture?
Um, so there's been quite a lot of research done on fertility acupuncture, and it's been done mainly in the East, where acupuncture is more common, but also some Western studies. And most of the data hasn't actually suggested an improvement in the chance of getting pregnant. Um, some studies did and some studies didn't, but overall, it hasn't shown a definite improvement. But, what some people say is that it helps to relax them, it helps to make them feel like they're empowered and they're doing, um, everything that they can to try and help to get pregnant. Um, and so that's really important because we know that if you can find a way to manage the stress of fertility treatment so that you can keep having treatment, you're more likely to get pregnant. So that's most likely the way that fertility acupuncture can help.
I've just brought a question over from Facebook as well. So can you see the questions yet, Michelle, or are they not coming up for your side?
There's one more pop down about to know when you're ovulating. Is that the one?
Yeah, that's it.
Okay, so it says to know when you're ovulating, what does the egg white mucus mean? And is that the time to try with intercourse or do you wait a few days? So we see the mucus change during a menstrual cycle. So it goes from being quite thick and white to in the lead up to ovulation and just around the day of ovulation, it looks more like really clear egg white. Um, and that means that you are in your fertile time. The problem is that discharge can vary from woman to woman, and things like infections can change your mucus as well. And also, if you've had surgery on your cervix or you take clomiphene treatment, it can affect the amount of mucus that you produce. So it isn't always all that reliable in everyone. Um, but women that are used to looking at it, can find it very helpful, and it does mean that you are coming up to the fertile time. And usually you will see once you've ovulated that will start to change again to be um, more of a creamy colour. So you want to be having intercourse when you've got that egg white mucus. So the next question coming through is when should you be referred if you know you have PCOS? Um, so PCOS is the most common cause of erratic ovulation, and we see loads of women with it. The symptoms can vary a lot from woman to woman. Um, and some people have very erratic periods or no periods at all. And to be honest, if you're in that category, I would be seen as soon as possible because if you never get a period at all, you are not going to be ovulating very often or at all, and you're not going to know when that is. So correctly timing your intercourse can be really difficult. So, you know, I would be happy to see you kind of as soon as you want to be pregnant, really. But you'd need to pay for a consultation because you wouldn't qualify if you haven't been trying a year. But if you're not having a period, y- you know, I mean, apart from optimizing your weight and all of that kind of stuff, some GPs will put you on treatments like metformin, which is a diabetes treatment, which sometimes can help some people ovulate. But often it doesn't, and if it does, it can take months to work. So look, if you're not getting regular periods, then, I would just ask to be seen as soon as possible. If you're someone with PCOS who does get regular periods, but they're long, so some people might get, say a 40-day cycle, but it's relatively regular. Um, it's probably a little more wiggle room to not be seen straight away. But you want to factor that in when you're using an app and things as well. So you want to be perhaps timing intercourse later in the cycle or having intercourse more regularly over a varied amount of time in case your ovulation is a bit all over the show. But again, I'd probably be happy to see you at maybe the 6-month mark if you weren't winning at that point. I mean, you certainly don't need to wait a year, if you're having irregular periods. It's just not fair. So the next question is if you have a high BMI, can you still do IVF? And the answer is yes, you can. Um, You sometimes don't respond as well to the IVF drugs that we give you, and we need to give you a higher dose. Sometimes scanning you is more difficult. We can't see the ovaries as well, and sometimes reaching the ovaries to collect the eggs can be more difficult. You also are at higher risk of having pregnancy complications. So things like gestational diabetes, high blood pressure, large babies, babies with abnormalities that we can't pick up on ultrasound because we can't see the baby that well, and a much, much higher rate of having a cesarean section. So people that have a high BMI probably have a 50% cesarean section rate. Um, we also know that there is some benefit to losing weight in terms of how you might respond to fertility treatment and then reducing your risk of pregnancy complications. But you have to balance that with age as well. So we know that if you are over the age of 38, there's probably not a lot of benefit to going away for a while because it can take a while to lose weight, um, and then coming back later when your age is then against you. If you are younger than 38, there probably is a benefit to trying to improve your BMI before you do IVF treatment. And increasingly, I'm seeing women in their 20s with extremely high BMIs, like in the 40s. And we do advise if you have got ovarian reserve and you're in your 20s and your BMI is that high, you are best to address it first before you try and do IVF treatment, both from a pregnancy success rate and also for your general health and your long-term welfare. The next question is, I talked to a doctor and she said I'm healthy to conceive based on my blood test, but we can't be eligible for public funding not in 2 years from now. Why is that? Um, I'm not sure I can answer that without knowing a little bit more about your background, but most likely you have unexplained infertility based on all the tests. So, um, if you have unexplained infertility, you require to be trying for 5 years to get enough points to get above the threshold, unless you try a couple of private IVF cycles yourself and don't get pregnant, or if you have slightly erratic periods and you try ovulation induction, you're not pregnant after 9 cycles, we can look at things again. But for people with unexplained infertility, that it takes 5 years to get enough points to get above the threshold. So I suspect that's why she's told you that. So the next question is, I am 37 and I'm going to use a sperm donor. Would you suggest doing IVF straight off the bat? And also, how many times can you try with an insemination? Um, so I would be guided by your doctor that you've seen, and that involves a discussion of what your ovarian reserve is like, how you're likely to respond to IVF. Have you been pregnant before? Um, and how many children you want to have. Um, if you want to have more than one child, sometimes IVF can be better if you're in your late 30s, because if we get some extra embryos that can be frozen, those then stay frozen in time in terms of chances of success, risk of miscarriage, the risk of chromosomal problems. If you do artificial insemination with the sperm donor, but you wanted to have children, 2 children, you would then have to do that one pregnancy at a time, and you might be another year or 2 older, which could affect your success rates. So it really is an individual decision, based on, how many kids you want, um, and, would you be happy if you just had 1 baby potentially? You'd also have to factor in your other medical background. So some people are better to do IVF from a medical point of view, say if you had endometriosis or something like that. Um, so the other thing to remember is if you decide to do artificial insemination, we don't usually advise you just keep doing it sort of ad infinitum. We'd usually recommend, up to 4 cycles. Um, and then we would review things and move to IVF at that stage. Some people do less and they might try 1 or 2 and say, well, I'm going to stop at that point and change to IVF. So just because you decide on one thing doesn't mean you can't change to something else if you change your mind. Next question is there a limit to how many IVF cycles a woman can do? Well, no. It can get more difficult to access the ovaries and collect the eggs because you possibly do get some scarring from when we collect the eggs. So sometimes you do find the ovaries get harder to see, harder to find, and it feels tougher when you put the needle in. The main issue in New Zealand is the cost. So we generally don't see people that do a lot of IVF cycles. In Australia, they have a different funding model where the government part pays for every IVF cycle if you're eligible. Um, and so at conferences I've been, they've had patient panels where people are talking about their fertility journey. You'd hear of people that had had 26 or 30 IVF cycles. And there's just absolutely no way in New Zealand that people could afford to do that. So we don't usually ever see that. And the next part of that question is there any long-term impacts, apart from potentially scarring on the ovaries? At this stage, IVF hasn't been around for a very long time. It's only been around for over 40 years. So we don't have any massive sort of long-term data, but at this stage, we don't think it increases your risk of ovarian cancers or anything like that. And probably one of the things people worry about the most is that we're going to use up all your eggs and you're going to go through menopause earlier, and that doesn't happen. Things like other cancers that are estrogen dependent, usually IVF doesn't have an impact on those. And so even people that have breast cancer and stuff, we can do treatment on them. But I guess we don't know if you did tons and tons of cycles and your estrogen was much higher than a natural estrogen level for a long time. High estrogen levels don't cause breast cancer, but they can be a promoter of abnormal cells to grow. So I guess we don't know if you did heaps of IVF cycles, there may be a risk that if you did have a breast cancer there, it could be promoted to grow. But yeah, we just don't have that data really. So the next question is how many failed ovulation induction cycles should I do before I step up to try IUI or IVF? So most of the research suggests if you're going to get pregnant with ovulation induction, it will happen about the first 6 cycles. But some people, if they've had a baby with that, will then come back and do more cycles. With clomiphene treatment, we are constrained to no more than 12 cycles because some old research did show that it can increase your risk of something called a borderline ovarian tumor, which is not a benign tumor. It's not malignant, it's kind of in the middle. So the data showed more than 12 months on clomiphene can have that effect. But with letrozole, we haven't got that data yet because it's much newer medication. It's only been used for probably the last 5 or 6 years, compared to clomiphene, which has been used for over 50 years. So usually, if we can get ovulation to occur and things look good on ovulation induction, we'd probably suggest you start thinking about a review appointment maybe after 3 or 4 cycles. And sometimes it takes a bit of time to get the specialist appointment, so some people might do another cycle or 2 while they're waiting for that appointment. Certainly by 6 cycles, if ovulation's occurring and you're getting intercourse timing right and everything, but you're not getting pregnant, that's when we'd be thinking about next steps from there. And normally, to make that decision about do you go for IUI or IVF, you'd need to make sure you've had a tubal potency test done and a detailed sperm test looking for sperm and anti-sperm antibodies in the semen to help you make your mind up. And also your specialist will talk to you about how many kids you want to have, and how much time you want to take to do treatment. So probably review it about 3 or 4 cycles, but definitely by 6. The next question is, when you go on contraception before your cycle, is that so the doctor has more control over your cycle so you don't ovulate, especially if your periods are irregular? Basically, yes. So we sometimes use the contraceptive pill if you don't ovulate regularly to help time or withdrawal bleed to commence the IVF. The other time that we use it is for the pre-implantation genetic testing cycles where our lab only has the ability to do a certain number of cycles a week, so we have to make sure people don't book on all at once. Um, Occasionally, we'll use it to turn off what we call dominant follicle development, which is when you start growing your one egg for the next cycle before your periods even come. So sometimes we use the pill for that, but mainly it is for timing. And particularly if you don't ovulate regularly, you don't want to be waiting 6 months to get a period before you start IVF. You're just sitting there twiddling your thumbs, basically. The next question is how many families are sperm donors able to donate to via the clinic? Yes, there have been limits in New Zealand because we know that New Zealand is very small, so we want to prevent siblings meeting and having relationships. It used to be 5 families. I think it's gone up to 7 families now. And we always ask sperm donors, have they donated to any other clinics? So we need to factor that in to make sure they haven't donated to other clinics. What is the waiting time for a sperm donor? It is long. So at least 2 years at the moment for a clinic recruited sperm donor. So when you have a consultation to discuss the use of a sperm donor, we often put you on that waiting list as a sort of a backup, but we do also talk to you about the option of recruiting a known sperm donor or advertising for a sperm donor as well, which can significantly speed up the process. There's still a sort of a processing time because they need to be assessed and screened for infections. So that's usually 4 to 6 months, but it can be a lot quicker than a couple of years. Some people do go overseas to access sperm donor treatment a bit quicker because some clinics can use these big world sperm banks, but COVID has obviously made that quite difficult.
Well, a great bunch of questions tonight, Michelle. That was fantastic.
Covered a lot of topics.
We did. Yeah, and I just wanted to say a big thank you for you, presenting the webinar tonight. And thank you for your time.
You're very welcome.
Really enjoyed your webinar, and it was such a broad topic. So, and you've covered it so well. So thank you. A lot of valuable information covered tonight. So thank you so much for your time. I know we've gone a little bit later tonight, but we've also had a great run of questions. I see there's a few more questions come through on Facebook. Are you happy to take those now, or would you like me to email those for you tomorrow?
Yeah, it's fine. Yep.
Okay. All right. So I've just joined and just saw a question about higher BMI and doing IVF. What is the BMI cutoff?
For public funding, it's 32. For private treatment, I don't know that we have a definite cutoff, but certainly the Royal College of O&G specialists suggests that we shouldn't do fertility treatment if the BMI is over 35. So technically we're not really meant to, but I always ask people, what is the lightest you've been since you've been an adult? So that we can get an honest evaluation whether people are ever going to get to a BMI of 32. And some people, they've never been there and they're never going to be. So what I usually suggest is they get themselves as fit and healthy as they can be before they have treatment, and we just accept that their BMI is going to be higher than average. But the key is, if you, as I said, I've seen quite a lot of people in their 20s with really high BMIs, and I really think there's a lot of benefit if you've got some time up your sleeve in terms of your age and ovarian reserve. I really think there's a lot of benefit to improving your health, so that you have better long-term outcomes. We do have some people that look at bariatric surgery, so weight loss surgery, to try and optimize their weight before they get pregnant. And it's increasingly common, and sometimes it can actually cure all their problems that they have. So it gets them ovulating again, gets rid of their diabetes, all of that kind of stuff. But you do go through a rapid weight loss phase over the first year, and so we don't recommend that you get pregnant in that rapid weight loss phase. But it is increasingly more common.
Just the last question for tonight, Michelle.
So what is the wait time for public funding if we are now just waiting on treatment for ICSI? So once you've been put on, it is about 12 to 18 months, and it's fluctuating a bit, and each clinic is ever so slightly different, but expect to wait perhaps up to 18 months.
Oh, thank you so much.
From the date you're put on the waiting list, not from now. Yeah.
Right. Cool. Thanks for that, Michelle. A lot of useful information. And I thoroughly enjoyed tonight. Make sure you connect with us on social media. We'll have more information on our next webinar on nutrition and fertility for next month. So I'd just like to wish everybody a good night. Stay safe and enjoy your break over Easter. And once again, thank you, Michelle, for your time tonight.
Oh, you're very welcome. It was a pleasure.
Oh, thank you. Good night, everybody.
See you.